Okay, okay. It was just just someone forgot to mute. Okay, awesome. Thank you. So I just want to emphasize that our next two speakers, Professor Edgerton and Dr. Parag Gad, they just published excellent paper on transdermal stimulation for kids with cerebral palsy, and maybe it will be a nice discussion between your team and Elvira, what you did with this patient, to discuss like what will be the best approach and if there are any pros and cons of using transdermal first, and if there are any comparison could be done between both approaches. So yeah, and again, if you want to mention anything like at this moment or you want to discuss later, I think it's going to be very important. Parag, I see you here. Do you have any thoughts on this?
Hey, Igor. I think the results look quite exciting, especially with some of the videos. I think there's a lot of potential with both approaches, obviously, but I think there may be some certain advantages with the epidural versus transcutaneous approach. We have never done the epidural with these kids, so but the videos that we see here look quite exciting.
Thank you. Yeah, I guess based on your results and videos, the results with scone therapy is really exciting, and it's really immediate effect, right, that you see right away. And you also see some late effect, right, when you do it for a while. So I wonder if it could be a potential to collaborate and maybe discuss options to implement your therapy before decision to go to epidural stimulation.
Yeah, definitely something that can be an approach. If there is long-term benefit of having the epidural implant and the ease of not having to put the electrodes on a day-to-day basis versus having an implant there, using the transcutaneous approach as a screening method to identify responders possibly. So yeah, definitely.
Awesome. Thank you.
Do you want me to go first, or Reggie, do you want to go first?
Either way, if you can, like whatever works best for you, for Reggie, please.
Sure. I can go ahead. Yep.
Okay, then maybe I can introduce Dr. Parag Gad. So we've been working with Parag for many years and started to work at UCLA. In Dr. Edgerton team. So Parag been working on multiple projects, starting from animals with spinal cord injury, designing new systems to bridge the injury with complex electronic devices. And right now he is working on human subjects with spinal cord injury and other conditions, including cerebral palsy, and also focusing on multiple other conditions like bladder dysfunctions, bowel dysfunctions, which is usually missing in most of publications. So, Parag, thank you so much for your time today, and please share with us your thoughts and vision on this field.
Thanks, Igor. Thanks for having me. So yes, like Igor said, we've been focusing on multiple pathologies as well as indications. I'm going to focus on two unique aspects today, just with this spinal neuromodulation. One of them being urinary incontinence, and the second being cerebral palsy, both within the framework of individuals that have some form of neurological dysfunction. Now, if you look at bladder function in general, the objective or the functioning for the bladder is essentially two components: storage and voiding. The ability to store urine up to a certain point, and when socially acceptable in adults, being able to void voluntarily. Well, at a high level, those are the two key components. There are four aspects that need to be kept in mind. One is the ability for us to sense a full bladder, so we know when to empty. Second, being able to reach a sufficient level of storage, so you can void only a few times a day. Ability to void voluntarily rather than being dependent on a catheter. And finally, being able to stay dry in between two voiding cycles. Now, as we know, there's a fairly large component of the nervous system that's controlling bladder function. The original thought was that the brain is primarily responsible for bladder control, which has been proven to be incorrect, with the spinal cord having sufficient level of control that is possible. Now, based on some of the early studies done in sensory motor function in individuals with spinal cord injuries, we wanted to assess if the same is true in terms of bladder control or not. So the first test we did was by positioning electrodes over the lumbosacral spinal cord between T11, T12, and L1 and 2 vertebral levels. Are we able to generate contractions in different components of the bladder by recording pressure changes with urodynamic catheters that are placed in the bladder? And what we observed was when these single pulses are sent in to the spinal cord, either at T11 or L1, L2, we're able to generate contractions in the bladder that are synchronous to the stimulation, very similar to what we see in lower extremity muscles from the hamstring and TA, for example. What this also shows us is, apart from being able to generate these contractions, telling us the spinal cord has neurons that are controlling or networks that are controlling the bladder function, we're also able to have site-specific stimulation. So the spatial resolution observed for bladder function is very similar to what's observed with lower extremity function, where there are certain areas that have higher control for bladder versus certain areas that have higher control for sphincter. Now, in the case of a urodynamic study in a patient with complete spinal cord injury, which is what you see here on the screen, there are a few characteristic responses that you see. The first being relatively low bladder capacity. The second being what's called the detrusor overactivity episode, or DO, which is a uncontrolled contraction in the bladder, as you see this pressure rising in the bladder. And the third being what's called detrusor sphincter dyssynergia, or when voiding is occurring, the sphincter and the bladder contracting at the same time. Now, in this particular case, we fill up the bladder starting from 0 all the way up at a continuous pace that's standardly done in clinical practice, urodynamic study. And once it reaches a certain capacity, what you observe is that the patient has no sensation of this contraction coming on, but there's a sudden contraction that occurs leading to voiding. But when voiding occurs, there's the DSD, or the dyssynergia between the bladder and the sphincter. Now, when we repeat this with the presence of stimulation, when we fill up the bladder up to a sub-threshold level, so about 80% of bladder capacity as identified with the previous run, and then wait for a good 2 minutes to make sure there's no DO episode occurring, initiate the stimulation as seen in this blue line. What we see is these little lines here that represent the stimulation artifact. There's an initial period where the sphincter is trying to increase pressure or closing, essentially the guarding reflex to keep the continence in place. But after it crosses a certain threshold, you see the relaxation in the sphincter along with the increase in the pressure in the bladder, or a contraction that's occurring. So here you can see a clear demonstration of the opposite response between the bladder and sphincter that's occurring, where as the bladder is contracting, the sphincter starts to relax, essentially reversing DSD. What's also true here is the absence of the detrusor overactivity episode, where the contraction that's occurring is essentially triggered by the transcutaneous stimulation. Now, this is stimulation delivered at 1 Hz over the T11, T12 vertebral level. And this is consistent with what we observed in our preclinical studies in rodents as well as in non-human primates. Now, that's just the acute effect. What's the functional improvement that is observed? When we deliver stimulation, we are able to increase the voiding efficiency within 1 session of stimulation from about 25% to 50%, which is a relatively large improvement in voiding efficiency, reduction in post-voidal residue. Along with that, we also see when stimulating at 30 Hz, we're able to increase bladder capacity by about 60% within a given cycle. So you see an immediate effect of the spinal neuromodulation on the bladder function, both in terms of voiding efficiency as well as in terms of bladder capacity and sensation. This is in a very controlled environment during a urodynamic study. What happens in a natural environment when what's called a uroflow, where the bladder is naturally full, and we were trying to enable voiding to occur. So as you can see in this particular case, let me run the video first. So here's an individual with a motor complete spinal cord injury, T4, Asia A, about 3 years post-injury. We asked him to initially void over a funnel that's measuring the amount of urine that's being collected, initially with voluntary effort only. And as you can see, no voiding is observed in this individual. And about 20 seconds after we initiate the stimulation, you can obviously see these contractions. He's also able to sense that he's going to start voiding. So this window, is present for about 10 seconds before voiding occurs, as compared to no sensation prior during urodynamic studies. So you see a nice flow of urine. We see about 30 to 40% efficiency in this case. There's still residue that's present, but we're able to induce contractions within with the ability to generate voiding with no DST. And over this period of time, you see this 36% voiding efficiency with a relatively good flow rate, as well as voiding that's occurring in this individual with complete paralysis within one session of stimulation. So all of these results so far are just the acute effects. The chronic effect of this is very similar to what we see in individuals with during sensory motor paralysis recovery with transcutaneous stimulation, where over a period of time, as you continue to receive training and stimulation, we're able to improve symptoms of urinary incontinence, storage, sensation, and the voiding efficiency. Now, a key difference here between training the bladder and training the lower extremity, for example, is you don't necessarily need to have them undergo any physical activities. They're able to sit on their wheelchairs and receive spinal stimulation. You're essentially tapping into this autonomic system and making it more automatic. So we expanded out our patient population to individuals with neurogenic bladder, and surprisingly, individuals with a stroke or MS or multiple sclerosis also have bladder function, with the symptoms being very similar to what we see in individuals with spinal cord injuries. So what we see here on the left is a patient with a stroke, versus on the right is a patient with a spinal cord injury. So very similar in terms of responses, both the DST as well as low bladder capacity and lack of sensation. Initially, when we deliver spinal neuromodulation acutely, we see this nice increase in bladder capacity, as well as the DST that's being reversed, much better control. And over the course of 8 weeks of training, we're able to see an increased bladder capacity, both in the absence and presence of spinal stimulation, as well as improved voiding efficiency. It seems to be more pronounced in the case where with the individuals with spinal cord injuries, but it's generally true across all forms of neurogenic bladder conditions. Looking at the group numbers, the bladder capacity increased significantly, as well as for spinal cord injury and stroke. The response, now all of this is in the absence of spinal stimulation. In comparison, the voiding efficiency did not seem to be significantly different, both for spinal cord injury and stroke. They're about the same statistically. Now, one of the reasons for this could be that bladder capacity may be a more consistent response where there's plasticity occurring in the spinal cord and brain, not requiring acute stimulation to observe increased voiding efficiency, whereas voiding efficiency and the ability to void may be a more long-term process requiring active stimulation for you to see that change. Or it could be that 8 weeks of stimulation is not sufficient to observe an improvement in voiding efficiency and bladder capacity. Now, with the change in bladder capacity and sensation, there's improvement in symptoms, where the ability to reduce the number of leaks between two voiding cycles reduces with an average of about 70% reduction in urinary incontinence episodes across all forms of patients, stroke, MS, and spinal cord injury, as well as we see a reduction in voiding frequency, where you see about a 40% reduction in voiding frequency across all patient categories. Now, from a symptom perspective, one of the standard surveys used to identify improvement in bladder function is called the neurogenic bladder symptom score, where a 5-point change in the neurogenic bladder symptom score is considered to be clinically significant. In our case, we see an average of 11-point change in the neurogenic bladder symptom score over this 8-week period, which seems to be consistent, where out of the 14 patients that were in the trial, 12 out of the 14 patients reported a 5-point or greater change in the MCID for the neurogenic bladder symptom score of 5 points, which is consistent across all the different patient categories. So how does this actually work? This particular video here will demonstrate a representation where when you deliver the spinal neuromodulation over the lumbosacral spinal cord, you have 3 essential effects. One, the efference from the spinal cord to the bladder and sphincter reduces the spasticity in the bladder and increases the tone of the sphincter. Second, the afferents from the bladder that are leading up to the spinal cord induce neuroplasticity plasticity in the local spinal circuits on the lumbosacral spinal cord. And second, the information that's leading up from the spinal cord up to the brain is amplified and essentially acting like a hearing aid to allow the brain to hear what the bladder is trying to say in terms of how full it is and how when it's actually trying to void. So a combination of these changes in the local circuits in the spinal cord as well as in the brain allow you to improve bladder capacity, decrease the spasticity in the bladder, and increase tone in the sphincter, resulting in overall better control as well as reduction in incontinence episodes between voiding cycles. Now, to quickly shift gears towards a more recent topic, which would be cerebral palsy. Let me open with this particular video here. This is a 2.5-year-old kid with spastic quadriplegia with a GMFCS level of 4 that came to us after having received extensive rehabilitation therapy at clinics here in Los Angeles, which are considered as the gold standard. And after about 6 months of therapy, he showed almost no improvement in his functioning. And when we introduced spinal neuromodulation, on the left is in the absence of stimulation versus on the right is in the presence of stimulation acutely 5 minutes apart. You can see him being able to actually take steps voluntarily. Now, what's important here is that the stimulation is delivered at a sub-motor threshold level. So if he was not on a moving belt, he would not be, we wouldn't be inducing any muscle contractions, and he would be sitting still. So that's a very critical component here, is the use of sub-motor threshold stimulation. For this particular case, if you look at the EMG patterns, there are some bursts that are present acutely, which are essentially attempts made by the individual to take a few steps. But as you can see from the goniometer change, there's almost no change in the ability to step until spinal stimulation is introduced, and you see this nice bursting pattern of alternating flexor extensor activity as well as consistent stepping across on the treadmill. Now, there are two kinds of patient categories that we came across. One was where they have almost no movement, and we're able to retrain the spinal and brain circuits to allow movement to occur. The second is who have some ability to step and are able to take some steps even in the absence of stimulation. But when you look at the EMG patterns quite closely, you'll see that there's miscoordination between flexor extensor activities as well as between proximal and distal muscle. Now, that can be acutely reorganized when spinal stimulation over the lumbosacral spinal cord is delivered. You see the kinematic patterns here are relatively the same, and there's no statistical difference between the kinematics of the hip and knee joints. But you see a slight increase in EMG activity between these two conditions. But what's more critical is when we look at the joint probability distribution plots, you see a fair amount of co-contraction present between the flexor extensor muscles in the absence of stimulation. This pattern is converted to a more traditional or quote-unquote normal pattern when stimulation is being delivered, where you see this nice L-shaped pattern as compared to a D or an O-shaped pattern in the absence of stimulation. So it's this coordination between different motor pools that are being restored when spinal stimulation is being delivered in these individuals with cerebral palsy. These are just acute results. We are currently testing the chronic effect of spinal stimulation while they're receiving training to see how this pattern changes, both from a electrophysiological perspective as well as a functional perspective in terms of changes in GMFM scores over a period of time. And finally, to conclude, I think as you all probably know, there's a fair amount of control that's present in the spinal circuits, and with the ability to transcutaneously stimulate and move the electrodes up and down the spine, we're able to activate multiple circuits and retrain the spinal cord and brain to improve multiple functions. And with the conditions such as stroke, spinal cord injury, or CP, pretty much all the systems are impacted, and the transcutaneous stimulation gives us that ability to retrain multiple circuits. So with that, I'd like to thank you all for your attention and happy to answer questions.
Thank you so much, Parag. It's a fantastic talk. Really great that you put so many questions in one talk and give us overview. So may I start from bladder control? So based on line of data and also final scheme, sounds like afferentation is quite important part of this effect. So did you try to stimulate peripheral nerves or combine therapy that already been in clinic, right, with peripheral nerves? Because this may add specific mechanisms which could be more selective compared to spinal cord.
In fact, it's the opposite. So peripheral stimulation is not as specific. And you know, in the past, PTNS, for example, or tibial nerve stimulation is a approved method for overactive bladder, but is actually ineffective for individuals with spinal cord injuries or any form of neurological condition. So we don't entirely know what the mechanism of action there is and why it does not work for individuals with a stroke or spinal cord injury. But clinically, it's been proven to be quite ineffective. So we have not really looked at that. But from a neurophysiological perspective, I think it sort of limits the possibilities because you're limiting your target with just the one nerve that you're stimulating. So we've not really tried that.
Mm-hmm. Thank you. Yes, it's interesting. So then you also have experience with epidural stimulation, right? And control of bladder functions, and even from red data, right? Remember when all those first videos with red urinate on treadmill with stimulation, with pinching tail, etc. So if you can extend this line from animal to human, how do you feel about potential difference between epidural versus transdermal neuromodulation to control bladder functions?
So I think the bladder function is a fairly specific, while it's a very specific function, it involves multiple organ systems that need to function together. You require your pelvic floor muscles, you require some of your potentially lower extremity muscles that all contribute towards improvement in bladder function. So while I think the results from our epidural studies from our rodent models, as well as what others have reported from rodents and humans, are consistent with what we're seeing with the transcutaneous approach. The ability to get a more global stimulation with the transcutaneous approach probably will make it more effective if there's a side-by-side comparison as compared to the epidural, because you're going to get the ability to activate pelvic floor muscles, the ability to activate lower extremity muscles simultaneously with the bladder and sphincter function. So I think I see more of an impact with the transcutaneous approach than the epidural in this case.
Thank you.
And the spillover to bowel function. I didn't really get into that, but a lot of these individuals that have neurogenic bladder also have issues with bowel function, and we see a direct correlation between improvement in bladder and bowel function.
Actually, I was just thinking to ask you this question. If you can share your experience with bowel functions.
Yeah, so this is fairly early on for us. But there's some anecdotal evidence that we have that in individuals that improve bladder function, there's a direct correlation to bowel and improvement in overall motility, improvement, reduction in time required to complete the bowel program, having a more complete bowel program, reduction in use of suppositories. Those are all anecdotal evidences that we captured. We still haven't completed a more formal study to know exactly what the impact of bowel function is, but there definitely is a lot of overlap, similar to what we see in the overlap between lower extremity and bladder. There's an overlap between the bowel and bladder.
Thank you. Thank you so much. Colleagues, please, if you have any questions, it's a good time to ask. Carlos? Oh.
Yes, thank you, Igor. Very nice talk, Parag. I would like to talk about your results with cerebral palsy. Do you know if there are some results, or maybe you're thinking of evaluating cerebral palsy changes after transcutaneous pulse stimulation? What happens in the brain? I mean, with doing electroencephalography, maybe magnetic resonance, or some imaging technique to see what happens after transcutaneous stimulation.
I think there's a lot happening. We don't know what's happening. That's for sure, but I'm almost certain that there's a lot that's happening in the brain. We definitely need to know more about it to understand what sort of ascending signals are going from the spinal cord to the brain, and how does that impact overall cognition. And I think there's mention of upper extremity function and memory. I don't think we have a good enough handle on knowing what's going in the ascending direction, but I'm almost certain that there is a lot that's happening there.
Thank you. And I have another question. Do you have any data on H reflex? I mean, talking about the spinal disinhibition or hyperexcitability in the spinal cord. Do you have any other data on that?
No, we unfortunately haven't done any reflex studies in these kids, for various reasons. One being, we've been conscious of how high we want to stimulate them and the induced activity. So we've avoided doing some of those reflex studies. So yeah, unfortunately, we don't have those data.
Okay, thank you.
Thanks, Carlos.
Thank you, Carlos. So please, if any other questions.
Hello.
Maybe.
Hello. Hello.
Yeah.
Oh, yeah.
Maxim, please.
Okay. I'll try to be short. Okay. Okay. So as Parag, as you mentioned that there are some persistent effects of the stimulation on the patients. So have you managed to some kind of, what is the duration of this persistence? So after you switched your device, how long does this effect persist on the patients?
Are you referring to bladder or CP?
Both, actually.
So for bladder function, we've seen a consistent effect over a period of at least 3 months after the therapy is stopped. So our updated protocol is where we do 12 weeks of therapy, and we see an extended, consistent response in terms of being able to maintain the level of dryness, bladder capacity, as well as symptoms for at least 3 months after the stimulation is stopped. So that's something that we see now consistently across multiple individuals. And it's been across the board with spinal cord injury, stroke, and MS. So that seems to be the case where the plasticity is sustained for this period of time. For CP, we don't know yet. That's something we're still identifying. We know that it's present after chronic training for maybe a few weeks, but we don't have a good enough data set right now to make that determination.
Right, thank you. Just one more question regarding the device. I just noticed that it's relatively small, at least on the photos, but on the photos with the kids, you have a actually wire that going out from camera. And how big is it, and what the current and the voltage of what? Thank you.
Yeah, so the voltage is, well, this is a constant current stimulation device. So I don't know if you can see my screen, but it's about the size of my palm.
Yeah.
So it's about small. It's small, and the kids can wear it quite easily. It doesn't really bother them in terms of the weight. We're able to identify. It's got a little belt clip at the back, so we can clip it onto their belt, and it can stay there. The currents generally for kids is anywhere ranging from 10 to 40 milliamperes, depending on what they require. So that's adjusted based on what we observe. Yeah, so it's a constant current stimulator with 2 channels.
Yeah, it's only 1 channel, isn't it?
2.
2 channels. Okay, thank you.
2 channels, yeah.
Okay, yeah, thank you.
Thank you so much. Parag, may I ask a general question? Because we have a few people here who are running currently clinical trials on spinal cord injured patients, right? And few people today actually expect to start the study, like Carlos, like Peter. So I wonder your thoughts on like practical aspects. What the best way to include bladder bowel functions control in ongoing or new clinical trials? Do you recommend to follow this routinely and maybe discuss with people who planning to run some studies to include those techniques and just get data routinely? How much time it will take from your standpoint, and what will be the best approach to follow up with this?
Yeah, so I think anyone that's doing any form of spinal cord stimulation trial, epidural or transcutaneous, in any neurological condition, I think bladder function should definitely be one of the assessments done. One, because of the quality of life, that impact that it has on these individuals, and second, there are now standard outcome measures that can be collected that can take as little as 20 minutes per assessment, and without any major equipment required, that can give you really critical data that demonstrate what the bladder function looks like. So I'm more than happy to work with anyone who wants to identify that and get that set up, because I think getting those kind of data would be critical, not just from a quality of life perspective for the patient, but also long term in identifying what a particular neurorehabilitation protocol does to bladder function and what the long term effects are.